Welcome to part 2 of this 2-part educational video series on the perioperative treatment approach in resectable non-small cell lung cancer. This video continues that discussion before shifting to the importance of the multidisciplinary team and the role of the surgeon, in particular, in ensuring patients receive appropriate treatment.
Our job as medical oncologists is to get them through preoperative treatment and make sure that you do everything to support them to make sure they don't have an undue complication from either the chemo or the IO.
I've had patients that said, I don't want surgery after that, and that's the patient. If the patient doesn't want surgery, that's their prerogative. But for the most part, people get through the regimens and they get onto surgery.
We are very diligent at our center at discussing all these patients with resectable disease prospectively in a multidisciplinary front. I think that's the best strategy. If you aren't in a center that has a functioning multidisciplinary thoracic tumor board, it can be difficult. Lines of communication, how do you get in touch with your surgeon? Sometimes surgeons want to operate as quickly as possible. You know, if it takes them 2-3 weeks to get a medical oncology appointment, they're probably going to go to the operating room first.
Yeah, I think these are tough issues that we're now dealing with, especially with these early stage lung cancer patients, where what's the right approach if they're not in the same system as you? How do you appropriately navigate this? Can be very difficult. I usually try to get the medical oncologist on the phone and actually have a phone conversation with that particular medical oncologist, even if they're not in our system.
That's an excellent strategy. We tend to see patients in the same area as our thoracic surgeons, so we're kind of integrated and have that as a luxury. But I would say, and I would echo, you know, you're talking from the thoracic surgery perspective. I'm talking from the medical oncology perspective. Get to know your surgeon. Get to know, how they think about these sorts of things. A lot of this data is new, and it really does change the standard of care or one of the options of a standard of care. So the messaging is all about collaboration and communication.
I totally agree. You have to have those open lines of communication.
Do you think lack of the multidisciplinary team involvement could be another reason more neoadjuvant chemo IO isn't being used?
We know that multidisciplinary team collaboration is linked to higher quality care and improved outcomes across the non-small cell lung cancer patient journey. 5-year overall survival rates of 33.6% versus 23.0% in the MDT group versus the non-MDT group is really crucial to understanding that patients are doing better when you have a multidisciplinary team. Along with other members of the MDT, surgeons are crucial and critical for helping make the detailed assessment needed for deciding on appropriate treatment regimens for patients with non-small cell lung cancer. This could be including evaluating for resectability of the tumor and, of course, the operability of the patient. With my surgical colleagues in the community, where tumor boards can be harder to schedule, I recommend using other channels such as an EMR chat if your EMR can support that, text messages, phone calls, and even emails to discuss critical cases with other specialists.
What is the surgeon's role in the patient journey?
The surgeon may be involved in all key aspects and steps in the patient journey, including educating the patient on treatment course and what they should expect with the different treatment modalities. This is why the NCCN guidelines state the following. Thoracic surgeons should actively participate in multidisciplinary discussions and meetings regarding patients with lung cancer, such as multidisciplinary clinics and/or tumor boards.
So as we know, treatment options for resectable non-small cell lung cancer are evolving rapidly. Historically, only about 50% of patients have been referred to medical oncology after surgery. In my opinion, patients with clinical stage 1B or greater or high risk factors should be referred to medical oncology for evaluation. In my opinion, this referral should come before surgery, so the appropriate treatment options, including perioperative and neoadjuvant, can be discussed with patients. So as a surgeon, how much of a shift in the paradigm has this been to thoracic surgeons?
Well, I think it's a big shift. I'm just going back to even like our boards. In our cardiothoracic surgery boards, we actually ask about EGFR, ALK, PD-L1 status. I think most of us are going to try our best to work with an oncologist. There's going to be circumstances where you can't or they can't, but we're going to try our best.
I think one of the important things is the fragmentation of care sometimes that we see, and you really don't have a good collaboration communication network for these patients. In that, at the end of the day, I've always said that our job is to get the right treatment to the right patient at the right time. And, we aren't doing as well as we should in this particular setting. So I think that's important to admit and try to do better.
You have to individualize the care to every patient. If I have a patient who's coming from far away, possibly even underinsured, trying to get them and coordinate a neoadjuvant approach might be very difficult, just from a logistical standpoint, getting an EBUS done, getting these mediastinal staging, neoadjuvant treatment, getting even getting NGS could be very, very difficult. In that type of setting, it might be more prudent to do a surgery first approach.
Well, that's all the time we have. I've thoroughly enjoyed getting your surgeon's perspective on resectable non-small cell lung cancer treatment needs and the importance of the multidisciplinary team. Thanks for watching, everyone.
We've come to the end of the second part of this two-part video series. You can view both videos at the URL on the screen.